Presenter is Andrew Cage. Andrew enters his third year as the head athletic trainer of the University of Texas at Tyler. Prior to his time at UT Tyler, he served as the interim athletic trainer for Morgan State. He will be entering the year working with volleyball, baseball, and men and women's golf. Prior to working at Morgan State, Cage completed his Master's of Education in Athletic Training at the University of Virginia in 2011. Andrew worked as a graduate assistant athletic trainer with the Cavaliers football and women's rowing teams. During this time, Andrew assisted in providing medical care for a Cavalier rowing team that won the ACC championship and finished sixth in the NCAA Division I standings. Welcome back, Andrew.
Thank you, sir. I got you. Sounds good. All right, guys, thanks again. So before I forget, as I start to drone on about these topics, on the Event Rebels app, when we're looking at the quizzes, it seems like they got switched. So the quiz for diagnosing medial tibial stress syndrome is actually going to be under the treatment and prevention of medial tibial stress syndrome portion of this as we start to kind of go through the questions at the end of this. But I'm pretty sure that we'll be able to kind of work together and make sure we have that all squared away. So once again, thank you guys for being up here, listening to me talk to you guys. It's always good to be here, always good to try to bring more evidence-based practice within our profession. And a lot of times when we talk about evidence-based practice, it's either things that are on the forefront of our knowledge or things that we're needing to change up, whether it's cupping therapy or Dr. Merrick's presentation last year with cryotherapy. And we talk about ankle injuries, knee injuries, things like that. But occasionally there's injuries that kind of slip through the cracks in terms of what we're really spending time talking about. And one of those ones that I was finding more and more is medial tibial stress syndrome. I know earlier a couple of people were talking about insurance companies and third-party reimbursement with their questions, and that's a huge thing when we look at our high school populations and even a lot of our college populations as well in terms of physician referrals and things like that. And one of the things with doing evidence-based practice for diagnosis of some of these kind of injuries that fall into those categories of does it warrant a physician referral, does it not, having a really deliberate and evidence-based approach to being able to diagnose these conditions is going to help us potentially save, one, our patients a lot of money, and two, save us a lot of grief of trying to decide, is this something I need to refer, is this something that I need to keep in-house? And hopefully this is going to give you guys a little more information as far as that goes. So once again, I'm going to take a brief second to thank my co-authors that are either here or that are back at their homes right now that helped make sure that we had this PowerPoint as seamless as possible. We're still going to find our hiccups, don't worry. And again, as I said yesterday, the Valley Athletic Trainers Association did provide some funding to assist with my travel and lodging here. Other than that, I have no disclosures that would affect anything about this presentation's content at this time. So yesterday we talked about evidence-based practice and the three-legged stool. Today we're just going to cut right to the point. We're going to start talking about our PICO question. And in this case, we're going to talk about our patients that are going to be patients suffering from posterior medial tibial pain. And does diagnostic imaging, so X-ray, MRI, diagnostic ultrasound, CT scans, bone scans, is that going to have a higher diagnostic accuracy compared to using an accurate history and performing a deliberate medical exam when accurately diagnosing medial tibial stress syndrome? So that's a mouthful, so we'll break it down again. So our patient population is patients suffering from that posterior medial tibial border pain. Our intervention is going to be really any form of diagnostic imaging because as we go through the research, you're going to find there's not enough on any one of these different topics to warrant being up here talking to you guys for an hour about one specific diagnostic imaging modality. And we're going to be comparing this to kind of what we do in the athletic training clinic, which is going to be taking a medical history, taking an accurate medical injury history, and performing a thorough physical evaluation of that patient and their condition. And we're going to see which of these is going to be better as far as getting an accurate diagnosis for medial tibial stress syndrome. But before we can do that, we have to ask ourselves, what is medial tibial stress syndrome? A lot of times we'll sit there and we'll tell people, well, it's pain on your medial tibia, it's shin splints. But really, that's going to be our blanket term for these things. And if we don't have a firm diagnostic definition of what a condition is, well, at that point, we don't know what we're looking for. So when we ask ourselves, why does the definition matter? Simply put, if we don't know what it is we're looking for, how are you ever going to find it? It's not even going to be playing a game of hot and cold. It's going to be just sitting there looking for a needle in a needle stack. And additionally, why is this important to us? Well, if you have a patient population that has running as part of their physical activity, minimum of 35% of those people are going to be affected by this condition at some point within their active career, whether it's during competitive athletics or if they're just people trying to maintain a healthy, active lifestyle once they're done participating in athletics. They're going to sustain medial tibial stress syndrome, about a third of your population. So if we think about the number of student athletes and patients that you guys see in your clinic, and we talk about the athletic trainers that have retired and have worked at the high school level and worked with literally thousands of student athletes, 35% of those people are going to have this condition. So it's a large portion of the people that you're affecting in their lives. So the first thing we need to decide is what we're going to call medial tibial stress syndrome. And there were a couple of studies that did a pretty good job of defining it when they started to take a look at it. The first, well, this was a later study than the other one we'll talk about, but in 2015, Ryan King and his constituents found that with regards to these lower extremity overuse bone injuries that were resulting from minor trauma to the bone, they were being commonly experienced in athletic populations. So that right there gives us a little bit of an incidence into the mechanism with that overuse. And they were saying that was going to be medial tibial stress syndrome, and they were going to define it as pain along that posterior medial border and the distal two-thirds of the tibia. So right there, they started to narrow this down for us. Now, in 2009, Moen and his colleagues, and yes, they said it did involve bone changes, or changes to the bone tissue potentially, if it was allowed to progress. In 2009, Moen and his colleagues came out and stated that they were trying to get that narrower definition as well, and they added in that this was going to be something that was occurring during exercise. So during physical activity, we started to get this posterior medial tibial border pain. That's going to be another telltale piece of this definition and another characteristic of medial tibial stress syndrome. Then they added in pain with palpation. So this is something that if we palpate this, our patient's actually going to be tender over that posterior medial tibial border. And when we start talking about our differential diagnosis in our patients with posterior medial tibial stress, this is a huge one. They said that they wanted to put the definition as pain over at least 5 centimeters. So that was kind of where they made it, and they admitted it was kind of an arbitrary number, but it was a number that they found within their patient populations. That's going to be their cutoff between what we are going to call diffuse pain and focal pain. And that's going to be very important when we start talking about our differential diagnosis. So now that we know what we're talking about posterior medial tibial pain that's going to be caused by exercise and overuse. It's going to be palpable, and it's going to be over 5 centimeters. Now let's talk about how we're going to find this condition. And we're going to start with our differential diagnosis, because as good clinicians, we always start with the differential diagnosis. When we have a patient come into the room and say, this hurts, we have in our mind, okay, it's probably going to be one of this list of things. Then we start performing our history and our physical exam, and we start ticking things off of our list, and we get down to it's one of these few things. We start to perform our special test, and then we really get close to our answer. So obviously, posterior medial tibial pain, we're thinking medial tibial stress syndrome. We're also thinking stress fractures, and a little bit more insidious and a little bit more of a medical concern potentially is going to be external compartment syndrome or even neurovascular entrapment based off of these collection of symptoms that we're getting described. So in order to be able to differentiate between these things and in order to be able to narrow this down to medial tibial stress syndrome, we need to be taking an accurate medical history. And it starts with a simple question such as, have you had a history of medial tibial stress syndrome? And then if they say yes, okay, well, did it ever progress to tibial stress fractures? And right there, that's one of the things that we can sit back and say, this person already has that predisposition because they've already had this condition in the past. Have they increased their training recently? Whether it's from frequency, intensity, duration. Have they been sitting on the couch all summer and then they started getting ready for 2 days the week before and were running 5 miles a day plus sprints? Did they change up their footwear? Did they recently just buy a new pair of shoes that have different insoles in them? Or have they not been changing their footwear? Because depending on who we talk to, the shelf life on our shoes and the most liberal of situations, it's going to be about a season. So maybe 3 to 4 months, that's the shelf life on a pair of shoes in a physically active population. When does this pain occur? Is this pain going to occur as activity is going on? Okay, well now we get back to that definition. So this is occurring during exercise. Does the pain start to subside when they remove themselves from activity? Because that's going to help us out with our differential as well. And is it a female patient that's experiencing menstrual dysfunction? And at the end of the day, what is this going to indicate? And we'll answer that question a little bit later because that's going to kind of tie into our female athlete triad. If they're starting to experience that menstrual dysfunction, it could be letting us know that there's some other things that could be potential concerns and potential risk factors for medial tibial stress syndrome, stress fractures, and things of that nature. So starting to take a quick look at our physical exam that we should be performing as clinicians, we're going to just start by taking a look at our patient. We're going to start by doing our observation. And we're going to check, obviously, the first thing we look at is, do they have excessive pronation or supination? Do they have that falling arch? Do they have that high arch? Does that change whenever they're going through motion or through their running phases? Do they have some mild swelling on their posterior medial tibia? Because there's some sort of inflammation going on here, whether it's in the bony tissue, the muscle tissue, or any of the other soft tissues in that area. So in the presence of that inflammation, there's a chance that we're going to have at least some mild swelling. Chances are, unless it's exertional compartment syndrome, it's not going to be a ton of swelling, though, especially in that compartment. Additionally, we can get some objective measures that we can start to actually take some numbers down on. First off, talking to them about that palpable pain. How far is that palpable pain? Does it hit that 5 centimeter threshold? Scale of 1 to 10, how much pain are you having through that area? Questions like that. Whenever they're going through their early support phases, you have your patient walking without their shoes on. Do they have an increased magnitude of medial longitudinal arch change? So does that arch either not move enough, or does that arch move too much compared to what you would normally expect in a healthy athletic population with good foot intrinsics? With a female patient population, do they have a high or a low BMI? And with a male population, do they have a high BMI? So the high BMI, that takes us to dealing with patients that are suffering from obesity or at least being overweight from where they should be in terms of being able to be healthy and participate in physical activity and just get around in life. Because as they start to weigh more, that's going to increase the ground reaction force. It's going to increase the amount of pressure that their lower extremities are going through as that patient's ambulating. But then we go back to that low BMI for our females. We go back to menstrual dysfunction for our females. Those are going to be giving us some warning signs that we might be dealing with a malnourished student athlete. If you have a malnourished student athlete, we're not necessarily even just worried about medial tibial stress syndrome. They could be opening themselves up for any number of things based off of the fact that now their body is still trying to perform physical activity, but it is not at a place where it should be really performing physical activity. It has other things that it needs to get well first before we have this person trying to do a lot of weight-bearing exercise. So these are all big, important questions and measures that we can take a look at that start to help us get an idea of what we're looking at. So further on those objective measures, we can look for hip abductor weakness, so checking those lateral thigh muscles out. In females, they've actually had studies that have shown that a limit in active and passive hip internal rotation causes an increase in medial tibial stress syndrome, whereas in males, the biggest culprit's been limited hip flexion. And while the studies that looked at these things didn't really go too far into the scope of what this really meant, they were able to kind of put that first layer of conclusion on it and state that these patients are having limitations in normal range of motion. So it's changing their gait mechanics, it's changing the way these ground reaction forces are dispersing through their lower extremity within the scope of our lecture, specifically the tibia. So we've gone through talking about our diagnosis, or rather our evaluation, talking about our history questions we need to ask, our big telltales from our objective and observational measures as well. So let's start ticking some of these things off of our list and trying to figure out how we can really start to take them away. So the first one, and again, one of the scarier ones, exertional compartment syndrome and neurovascular entrapment. The complaints with this are going to be a little different than those complaints we talked about with medial tibial stress syndrome. And they may still talk about that posterior medial tibial pain, But in addition to that, we're also going to have them say that they feel like they're having cramping within those muscles on that posterior medial tibia, tightness just kind of within that entire leg. And if you talk to them and ask them, is it muscle tightness? They may tell you, okay, yeah, it's a little tight in the muscle, but it feels like the skin's tight too. That's going to be another big one. And they're going to start to describe some burning or aching pain. And this is going to be true for that exertional compartment syndrome and that neurovascular entrapment. Now we're starting to get those neurovascular symptoms in addition to this condition. And when the patient's at rest, every other symptom's gone away, whereas with medial tibial stress syndrome, we can still kind of provoke some pain with palpation. With exertional compartment syndrome, that tenderness, as a general rule, is going to be gone, and that patient's not going to be tender again until the next time that they go through activity and activate that exertional compartment syndrome again. And it's going to take a little longer with our medial tibial stress patients to get that pain to go away, whereas with these exertional compartment syndrome patients, these patients are going to have, in some cases, almost an instantaneous subsiding in pain. And lastly, and this one's probably, if you've ever seen this performed, a little more barbaric than trying to use signs and symptoms to differentiate, but if you do kind of get to that point where you're suspecting medial tibial stress syndrome's not in the table anymore, and it's more that exertional compartment syndrome and neurovascular entrapment, what they'll have to do is they'll have to perform intercompartmental pressure measurements using this gauge you see here, which a lot of times it seems like it might be more painful than the condition itself. But when you talk about the risk for muscular necrosis and things of that nature, it's still something that's possibly needed. Tibial stress fractures. This one's going to be a little more challenging because of how closely it's going to mimic medial tibial stress syndrome and when we look at our pathology and our symptoms. But there's going to be at least enough right now in research to where we can make a few judgment calls, and I say judgment loosely because we can make some pretty decent calls that's going to tell us medial tibial stress syndrome versus stress fracture. So still at this time, and we're getting into the PICO question, or getting back to the PICO question slowly, radiographs are going to have a very low sensitivity, so they're going to be very poor in terms of being able to determine whether the patient does or doesn't have that condition. Reason for that being, a lot of times we don't end up getting our calcification of that bone, even with a stress fracture, until about 6 weeks out. Now, with this condition, here's where our 5 centimeters come in. If we have a patient that has focal tenderness, so over less than 5 centimeters, then we are talking more risk for stress fracture. If it's more diffuse, it's at 5 centimeters or greater, we're talking about a situation where we're dealing with more medial tibial stress syndrome. And by and large, this isn't going to be something that's a hard and fast rule, but it's at least getting enough traction and enough ground within literature to where we can say that a little more safely. And another big one when you're talking to your patient about their medical history and you're going through your physical exam is they're going to have night pain. So this is going to be that patient, they go home, they get done taking a shower after their workout, they lay down, and they still have that sharp pain in that tibia, in that focal area. That's going to give you an idea that we might be dealing with the tibial stress fracture versus medial tibial stress syndrome. And then if you use either a tuning fork or the bumper percussion test, you're more likely to elicit pain through that area of that tibia than you are with a patient with medial tibial stress syndrome. So that's going to help us narrow down and kind of start to, like I said, tick off some of those things that might be a little more concerning. Not to say medial tibial stress syndrome isn't concerning when we go through our differential diagnosis. So before we start talking about these different radiographic images or diagnostic imaging tools, let's just take a quick review of diagnostic accuracy, since a lot of us haven't really seen this since we were taking assessment back in undergrad. So specificity and sensitivity are what we talk about whenever we're talking about conditions and talking about the accuracy of a special test, a diagnostic imaging tool, or anything of that nature. So starting with sensitivity, this is going to be what we call our true positive rate. And what our true positive rate means is that this is going to tell us how well this special test or this diagnostic imaging tool is going to confirm the presence of a condition. So if you have a high sensitivity, you're going to be able to rule in a condition on your differential diagnosis. And it's going to be indicative of how well that tool is going to identify a patient that has that condition. Specificity, on the other side, is actually going to be our true negative rate. So now we're talking about how well this diagnostic imaging tool, in the case of this talk, rules out a condition. So it's going to describe the ability of this tool to determine or detect patients that do not have that condition or the absence of that condition in the presence of a negative test. So now that we've got that kind of situated and have gone through our very brief review on that, let's start with radiographs, so x-rays. And we had 3 studies in the early 2000s that all kind of came to the consensus that using radiographs to diagnose medial tibial stress syndrome is not appropriate. And when pressed on this topic, the authors all came to the same conclusion that, like with that medial tibial stress syndrome versus the stress fracture slide, we're not going to be getting calcification until 6 weeks with a stress fracture. If we're talking about medial tibial stress syndrome where there's no calcification occurring, an x-ray is not going to show us anything because we need callus formation to be able to actually have an x-ray that's going to show us any sort of structural changes outside of actual true acute fractures or healed fractures or things along those lines. Then Moen et al. In 2009 took a look at the sensitivity and specificity of MRIs. Within their study, they found some interesting numbers. So 79 to 88% sensitivity for ruling in medial tibial stress syndrome. And 79 to 88 is not terrible. Most of us would take an 88 on a test a lot of times, depending on the course. But at the end of the day, when we talk about the average cost of an MRI for a patient with good insurance and they're out of pocket that they're still paying on it, it's still something where if we're not really able to chalk it up and compare it well to our gold standard, we'd still like to see a little bit of a higher sensitivity. The range on our specificity is interesting. So we have a 33 to 100% specificity to be able to rule this condition out, which is to say the accuracy is kind of all over the place depending on the randomized control trial that you're looking at. And if I get told that I'm either going to get 33% of something or 100% of something, I'm not going to be very inclined to take those odds because that's a 67% swing as far as how well this tool may or may not work for this situation. And additionally, they took a look at bone scans and found a similar sensitivity and specificity rate to MRI. They did not give actual numbers on this one. They just mentioned that they were going to be similar to the MRI for diagnosing medial tibial stress syndrome. Next, they looked at high-resolution computed tomography, which found only a 42% sensitivity, but 100% specificity. So this computed tomography is going to be really good if you want to find out you don't have the condition, but if you do have the condition, you're going to end up with a lot of false negatives with use of this diagnostic imaging tool. And then Gaeta and his co-authors came out with 2 studies back-to-back years where they actually kind of put the stamp on this and said that right now within sports medicine and diagnostic medicine in general, clinical diagnosis is currently going to be used as our gold standard when diagnosing medial tibial stress syndrome, and we're going to use we're going to use physical exam and medical history as our comparison to these diagnostic images. And this is what's been going on across the board within all these different researches we're talking about. And these authors came and said, well, if this is what's our gold standard, this is what we're comparing these expensive diagnostic imaging tools to, what would be our rationale and what would be our reason to change what we're doing as clinicians, and why would we start spending thousands of dollars increasing premiums for our patients' insurance if we have these researchers telling us that diagnostic imaging isn't going to help us out any more than us talking to our patients and performing a thorough physical evaluation of them. So right now, their kind of conclusion was that use of these tools or any additional diagnostic imaging tools should be limited unless you get those concerns for either tibial stress fractures or exertional compartment syndrome and neurovascular entrapment. So this one's going to be our shorter one because when we get into treatment, that one's going to take us a little longer to make up our time there. But we need to know how to differentiate these conditions from other conditions that have similar presentations and similar signs and symptoms. Remember, when we talk about that external compartment syndrome and neurovascular entrapment, we need to check for that sensation of tightness or cramping. We need to make sure we're keeping an eye out for that burning or aching pain versus that sharp pain you would expect with medial tibial stress syndrome, because that's going to be indicative of some sort of neurovascular involvement. And then when we talk about stress fractures, keep in mind the name of the game here is focal versus diffuse. So that 5 centimeter range, if it's smaller than 5 centimeters, we're talking about a more focal stress fracture type situation. If it's larger than 5 centimeters, we're talking about a more diffuse situation that's probably more in keeping with medial tibial stress syndrome. And again, that night pain and that pain on percussive tests, so tuning forks, bump test, and things of that nature. So clinical bottom line with this area here. Without a standardized definition, we're going to have a very hard time determining what is going to help us diagnose medial tibial stress syndrome. There have been authors that have been trying to put forth their standardized definitions or trying to put forth their definitions as that standard. But at the end of the day, we're still needing more and more research to be done to where we can actually just come to a clinical consensus as athletic trainers, physicians, physical therapists, anybody else in the sports medicine realm of what medial tibial stress syndrome is, so that way we can all diagnose the same condition with the same assessment cascade. Now, this is a nice long way right here to tell you guys that we all need a clear understanding of the signs and symptoms of medial tibial stress syndrome, so that way we can use the most accurate diagnostic tools we have available to us to be able to differentiate between medial tibial stress syndrome and these other conditions. Now, in order for us to do that, we need to know the questions to ask first off. So that first question we ask, when does this pain occur? Does the pain occur during exercise? Okay, now we're talking possible medial tibial stress syndrome. You're having pain at night? Okay, something else is going on here, whether it's stress fracture, tumor, something along those lines. When does this pain start to subside? Does it subside gradually after exercise? Does it subside immediately after exercise? Does it not subside at all? And based off of those answers that we get from our patients there, that's going to go back to our differential and give us a few more ideas of what's going on. Have you changed your footwear recently? And this, based off of whether it's a yes or a no, that could go either way. If they change to a more rigid shoe that doesn't absorb shock as well, that's a sign that we might be dealing with medial tibial stress syndrome. If they're wearing the same shoes they got their freshman year and they're a junior now, that's still another sign that we might be dealing with medial tibial stress syndrome. And have you changed your activity recently? Have you ramped up any of your activity? Have you changed your exercises or your program you're putting yourself through? And then know our telltale signs and symptoms specific to medial tibial stress syndrome, starting with as simple as that posterior medial tibial border pain that occurs with activity, and then pain that we can palpate, pain that we can provoke through actually touching and going through this area on these patients. And then pain over an area of at least 5 centimeters. We keep coming back to that number because that's one of the big takeaways I want you guys to look at whenever we're trying to ask ourselves, with our patient population, do I send them for x-rays? Do I send them to the team doctor? Do I hold them on site? 5 centimeters, unless there's a growing body of evidence that you have, or their parents just say they absolutely want to go get x-rays and they don't care, or they want to start that process. Because at the end of the day, most insurance companies are not going to order an MRI or a CT scan or a bone scan without that x-ray first. In today's third-party reimbursement system, we need to keep an eye on these things here to try to give us the best tools available to us to work with our patients and our patients' families and caregivers to make the right clinical decisions for referral. So now, like I said, I'm pretty sure it's flipped to where these diagnostic questions are going to be under treatment questions. And I'm pretty sure I saw on my own slides, this was through my fault on this one, that one of the questions got flipped from one of these as well, but don't worry because we're going to go through them together. So our first question, which of the following is not a symptom of medial tibial stress syndrome based off of the discussed clinical definition? So pain on the posterior medial border of the tibia, is that a symptom? Yep, that's one of our symptoms. Pain over an area greater than 5 centimeters in length. I said that about 15, 20 times, so probably pretty sure. Palpable pain, we said that we're able to provoke that one as well. But that focal pain or tenderness, that's not going to be medial tibial stress syndrome. Now we need to be at a concern for a stress fracture. So this one is the question, like I said, that we'll get to go over here again here in a second. But which muscle, long thought to be a major factor in medial tibial stress syndrome, has been found to have no attachment along the posterior medial tibia? So here's going to be our spoiler alert for the next PowerPoint. Posterior tibialis, and again, like I said, we'll go over this one next time. I got that one mixed up on my slides and on my quiz. Then medial tibial stress syndrome has been found to affect as many as what percentage of runners at some point in their lives? So this goes back to why is this such an important condition for us to know? And it's because as many as 35% of the patients that you see that are involving or incorporating running into their activity are going to experience medial tibial stress syndrome at some point in their active careers. And then, which of the following discussed as the best approach to diagnosing, which of the following was discussed as the best approach to diagnosing medial tibial stress syndrome based off of our modern research? And the one that should stick out to you is radiographs, because remember, we're talking about diagnosing medial tibial stress syndrome, not diagnosing stress fractures, not diagnosing exertional compartment syndrome, not diagnosing acute fractures. And since we're talking about a soft tissue condition in most cases, then radiograph is not going to show us anything because there shouldn't be any calcification. So that thorough medical history and that deliberate physical exam should be our gold standard that you and I use when we are going through this. And then lastly, true or false, the lack of that standardized definition of medial tibial stress syndrome increases the difficulty of diagnosing the pathology, or at least creating a standardized methodology for diagnosing that pathology. And the answer here is going to be yes, that's true, that this is going to affect our ability to set up a standardized diagnosis methodology for this condition. So like I said, this one was a little shorter because I knew that our next one was going to probably potentially run a little longer. But as you can see here, and once these PowerPoints get distributed to you guys by the VATA, there is a number of works cited on this, but I felt like this was going to be a good, worthwhile area for us to go through to start to kind of consolidate this information for you all. So kind of for this first portion, let's see if we have any questions.
One person has asked, how likely is it that medial tibial stress syndrome can turn into a stress fracture?
So when you look through the research, and as you saw, there was a litany of articles that were going over this, there wasn't really a standard answer to that question about medial tibial stress syndrome and the chances of it turning into a stress fracture. Once we start talking about the treatment side of things, the most orthopedic surgeons that were polled during some of these research studies felt like the risk was high enough that they needed to remove patients from physical activity once they started to experience medial tibial stress syndrome until those symptoms subsided, for fear of either exacerbating that medial tibial stress syndrome or increasing the risk for stress fracture. So there's not a standard number on it, but there's enough of a concern for this condition to turn into a tibial stress fracture that most orthopedic surgeons that were polled recommended removal from activity until symptoms subsided.
The next question, what would you suggest to cross-country and track coaches to reduce medial tibial stress syndrome?
All right, so that's going to be one of the things that we go over a little bit more in this next portion of this. But for the most part, it's going to be identifying those patients that have, say, some sort of mechanical deficit, starting to put them on an exercise program that's going to assist with that. The types of insoles and shoes are showing more and more results as far as preventing medial tibial stress syndrome from starting to occur. And then also starting to gradually increase activity, because most of these patients that were dealing with medial tibial stress syndrome were the patients that ramped up their activity, whether it was intensity, duration, or frequency, entirely too quickly.
Anyone else have any questions? I'll come to you. Okay, I think we can begin chapter 2.
All right then. So like I said, this portion we're going to talk a little bit longer because within this area, we're not just talking treatment, we're talking prevention as well, which is going to hopefully kind of coincide with that one question we had from this last portion of the PowerPoint. But again, we're going to take that evidence-based approach that we've applied already this week to cupping therapy, vestibular rehab, and diagnosing medial tibial stress syndrome. And we're going to talk about treating and preventing this condition. Because now that we know that a patient has medial tibial stress syndrome, we need to take that next step. We need to start to actually figure out what we can do about it, or in a perfect world, we're going to figure out how we can prevent this. And of course, we get to start with our PICO question, and in this case, we're going to have PICO questions because we're talking treatment and prevention. So from a standpoint of prevention, our subjects we're looking at are going to be subjects that are performing distance running, so that track and cross-country population fall in perfectly with this. The populations in most of these studies we talk about are actually going to be people in the military because they are a population that's a captive audience that is going to be performing a lot of weight-bearing cardiovascular activity throughout their training regimens and their personal fitness regimens. And within that patient population, does the use of shock-absorbing insoles reduce the incidence of medial tibial stress syndrome when we compare it to just wearing the standard insoles that were in our shoes the day we bought them? So again, we're going to break that down one more time. Our patients are subjects performing distance running. Most of these people are servicemen. They're going to be using an intervention of shock-absorbing insoles to compare to our standardized insoles, and they'll be looking at the reduction in the incidence of medial tibial stress syndrome. For our PICO number 2, now we're talking about treatment. And our intervention we're going to be looking at specifically is going to be therapeutic exercise compared to just kind of our standard conventional treatment. And we're really going to talk about why standard conventional treatment for this condition, and additionally even standard prevention for this condition outside of insoles change, is not going to be very practical for our population. So again, these are going to be subjects that are already suffering from medial tibial stress syndrome, been diagnosed with the condition. They're going to be put on therapeutic exercise programs compared to conventional treatments. And our outcome measure is going to be a reduction in return to running time. So were we able to get these patients back faster to running if they were performing a therapeutic exercise program? So this was one I had to play around with a little bit about where to put this portion of the talk, and that's going to be what causes medial tibial stress syndrome. And the reason I decided to put this in the treatment and prevention area of this is if we're going to be treating a condition, if we're going to try to prevent a condition, we need to know how it's happening and what causes it, so that way we can try to take those chains out of the link, so to speak. So early on in our research, and this ties back to that last question from the last survey, medial tibial stress syndrome was thought to be caused by tendinopathy or strain that was causing inflammation of our posterior tibialis. And the other culprit that was looked at a lot was inflammation of the periosteum. And for the longest time, even whenever I was in undergraduate school, this is something that was put forth as possible causes of medial tibial stress syndrome, or shin splints when we use that blanket term. And it's kind of shocking, and it kind of shows us a little bit of the interesting dichotomy, because if you talk to different clinicians and different researchers, they're going to tell you that the research that comes out today in 2017 isn't going to really be implemented into clinical practice for another 16 or 17 years in terms of a widespread being taught, being implemented, and then being utilized in a clinical practice. 16 to 17 years. So the information you guys are getting today in terms of being broad scope used across the board, 16 to 17 years, so 2033, 2034 is when we're really going to start to see these changes. If you walk into a high school in Nome, Alaska, you'll finally see those changes across the board. But Beck came out with a study in 1994 where they took a look at cadavers and dissected out the musculature of the lower extremity and found that while there were attachment sites for the soleus and the flexor digitorum longus muscles along that lower third of the posterior medial tibia, which a lot of times in our patients, that lower third and that distal 2/3 is where we look at our pain, but there was no posterior tibialis involvement in terms of having an attachment site along that lower 2/3. Then in 2016, another study came out that took a look at 22 cadaver legs And again, we found that soleus and that flexor digitorum having their attachments there on that posterior medial border, where we commonly attribute most of the pain symptoms occurring with posterior medial tibial stress syndrome. But there was still no posterior tibialis attachments. So that right there, they use that as their grounds for stating that posterior tibialis doesn't necessarily have the effects we thought it had with medial tibial stress syndrome, because it would have to have an attachment site closer to that area for it to truly be a major issue with regards to that strain and everything of that nature. Now, it may play a role in muscular imbalances, but it's not our primary culprit. Now, talking about periosteum and inflammation of the periosteum, or that outer lining of the bone that we see in this picture here that they have it dissected out, there were 2 histological studies that took place where they took a look at medial tibial stress syndrome patients and performed analysis of their periosteum and did not find any inflammatory cells in those sites where the patients were suffering from medial tibial stress syndrome. So there were no inflammatory markers, so there was no inflammation in the periosteum. So they were able to relatively definitively define this as a situation that periosteum inflammation just really wasn't as big of a factor in medial tibial stress syndrome as we thought it might be. But so now we know what it isn't, we need to figure out what the more likely risk factors are. So like we talked about last time when we were looking at our clinical observations and our clinical qualitative and quantitative measures for diagnosing medial tibial stress syndrome, we need to be able to look at BMI of our patients, because a male with a high BMI, so an obese male that's putting more pressure and having more forces dispersed over that tibia and that lower extremity, is going to be at a higher risk for medial tibial stress syndrome. Again, the higher low BMI in our female population is going to be a concern as well. Once again, the same thing with obesity. But on that other end of stuff, taking a look at either disordered eating or malnutrition for whatever reason it may be. Because in certain populations across the country, their disordered eating is not a voluntary habit. Some of these patients, depending on their socioeconomic standings, are not able to get the nutrition that they need at home in order to have good bone health or good musculoskeletal health in general. But at the same time, we still need to be able to identify these signs that this is what's going on. Next, we talk about decreased hip internal rotation, and we brought that one up last time, but again, we kind of can sit back and say there's going to be some mechanical changes if we can't rotate our hips as well during our phases of gait. And if we can't do that, those forces have to go somewhere. The tibia is the largest bone in our lower leg, so chances are that one is going to be the one sustaining most of those forces. And then an increase, we talked about this one last time again, that increased magnitude in medial longitudinal arch changes during that early support phase. That lets us know that they don't have good foot intrinsics to help control that arch. And if that arch isn't functioning properly to both work as a lever and as a shock absorber whenever we're going through gait, those forces are going to get distributed somewhere. You might end up with a navicular stress fracture, first met stress fracture, but a lot of times you're going to have those forces distributed up to the tibia as well. And then this one was another interesting area, inversion and eversion strength imbalances. So in patients with medial tibial stress syndrome, they had stronger everters in terms of concentric strength than inverters. So that's again where I say we talk about posterior tibialis isn't going to be as big of a player as we thought it was from being strained or inflamed or anything like that causing these problems. But a weak posterior tibialis, now that might be causing some of these problems as well, because posterior tibialis is one of our inverters. And if it's not functioning properly, those everters are overcoming it. That's going to change our gait. That's going to change the way that our body distributes those forces through that lower limb. It's going to increase our risk of medial tibial stress syndrome. And the reason that we hammer this home is because when we talk about some of the research here in a minute, you'll see how vague some of these therapeutic exercise programs are. But keeping on our risk factors, the next one up we talk about is going to be that rapid change in weight-bearing training regimens. So whether it's weightlifting, whether it's cardio, these things are both going to have effects on the forces that are being distributed over our lower extremity. And again, that can be that increase in intensity, so the load you're putting on, how much you're sprinting, It could be the increase in frequency. You've gone from working out every other day to working out every day, or working out every day to working out twice a day. And increased duration. So talking about our distance athletes, especially if you talk about, say, a cross-country runner that was in his running club in middle school, or was running the mile or the 2 mile in middle school, and now he's running a cross-country regimen at the high school level, and then turns around and ramps it up even further by going to run at the collegiate level. So with all this information in mind, we can use some of these risk factors to help us figure out how we can prevent this condition. Now, the first study that came out about supplementation, or the most recent study rather, was in 1992, because we're trying to find what we always talk about, good bone health. Mom and dad always tell us, drink your milk. If you don't drink your milk, you're not going to have good bones. We always get told, oh, that kid broke a bone. He must not drink enough milk. So we've always had that idea in our mind that we need calcium to have good, strong bones, which we do, but trying to figure out if that's really what's causing this condition, or if increasing our calcium intake affects our bones. Well, if we look back at those two studies that looked at the analysis of the periosteum and found that it wasn't inflamed, right there we know, okay, well, maybe it's not truly the bone itself that's having the major issue. But at the end of the day, this study still went ahead and looked at the effects of calcium supplementation on preventing medial tibial stress syndrome. So with their patients, they added in 500 milligrams of calcium supplement to their intervention group, left the other group the same, and found no significant difference, which, looking back at those histological analysis, we can kind of assume that this is what they were going to find, was that changing up calcium supplementation didn't really have an effect on the incidence of medial tibial stress syndrome. Moving up to 2006, Johnston et al. Got a very good sample size, because they were able to take 2,700 shipmen in the United States Navy and take a look at what they could do to prevent it. What they found was that if they reduced training frequency, duration, total running distance, and intensity, there were significant decreases in injury reduction. Is this practical for the military? Is this practical for your patient populations? Who here wants to go talk to your cross-country coach or your track coach or your football coach and say, hey, coach, I figured out how we can get fewer injuries? They're going to say, that's awesome. How are you going to do it? We practice once a week before the game, and when you practice, you go as light as possible. Nobody? Okay, so that's really not going to help us out much as athletic trainers. So what they also cited, though, was that there were 12 studies that were at varying levels of quality, but 12 studies found that using shock-absorbing insoles decreased the incidence of medial tibial stress syndrome by as much as 50%. And they even admitted that the quality of the evidence was moderate at best, so it wasn't bad evidence, but it just could have been better. But if we're talking about decreasing this incidence by 50%, they did say that that was still something worthwhile and something we still needed to consider whenever we're taking care of our patient population. Because, say it's moderate and it's not 50%, it's 33%. Like we said, if 35% of your patients are having this condition already, knocking that number down by a third is still something that's worthwhile to consider. So Ryan King starts to show up again. He's another person that's been doing a lot of research on medial tibial stress syndrome. But they were really paying very close attention to those BMI numbers. So a lot of times you'll see it in NFL training camps where teams will have somebody that shows up overweight, and they get to spend the whole practice on the stationary bike, and then after practice they're consulting with a nutritionist to get their weight down, because those teams are throwing millions of dollars into these athletes and their patient population, and they recognize that that higher BMI is increasing their risk of injury, not just for medial tibial stress syndrome. So that's something with counseling our patients as sensitively and as delicately as possible on decreasing BMI for our high BMI patients and increasing BMI for our low BMI patients in terms of increasing health just in general, but also preventing medial tibial stress syndrome. It's going to be something that's important for us all to be trying to do. But what they concluded throughout this was that if we can participate at that healthy weight, you're going to reduce the risk of medial tibial stress syndrome and injuries in general, because that patient that's at that healthy weight, that indicates that they're probably generally physically more fit than the patients that are falling out of those parameters. So they're better equipped to deal with the forces or the demands on whatever sport they're participating on to begin with. Another study, this was a good randomized controlled trial where they took a look at standard insoles versus custom semi-rigid insoles. So these custom insoles were taking a look at, one, providing that shock absorbing padding, but then since they were semi-rigid, also making sure that the patient maintained a good arch, that they weren't overpronating and things along those lines. And after 3 months of training, they found a significant reduction in their intervention group for medial tibial stress syndrome occurrence. And not only was it significant, it was pretty clinically meaningful too, because the patients that were wearing standard insoles had 38% incidence. So that kind of is keeping in line with that 35% of athletes or running athletes are going to experience medial tibial stress syndrome. But in our control group, there was only an 8% difference. So that's even greater than a 50% difference right there within this very well-conducted randomized control trial. So right there we have some decent bread and butter for how we're going to prevent these conditions. If one of you guys can find the coach that lets you have one practice a week as light as possible, you're going to have a lot fewer injuries and you're going to have a much easier time. But failing that, medial tibial stress syndrome, again, this is a condition that relies on treatment versus prevention a lot of times. We are not just within athletic training, but we are a reactive society. We don't try to fix something until it's broken. So more often than not, we're not going to be proactive. We're not going to be preventing injuries. We're going to be dealing with them once they get them. And then whenever you're talking about being in the middle of your 11 or 12-week football season plus postseason, you're not going to be trying to prevent injuries. At that point now, you're stuck having to manage injuries. So being able to educate your coaches beforehand and using your clear understanding of the causes and the predisposing factors that we have with these conditions is going to be important and incredibly critical for you guys to decrease the amount of injured patients that you're running into with medial tibial stress syndrome. So, unfortunately, as much as we like to believe mom telling us that you need to drink as much milk as possible so you don't break your bones, calcium supplementation is not going to help us out with medial tibial stress syndrome. It's not going to be effective because, again, more often than not, if it's medial tibial stress syndrome and not stress fractures, the bone's not necessarily the problem to start with. Now, with that being said, the most effective ways of preventing this condition from occurring in our patient population and in the military patient population, at best, these methods are wildly impractical. But in the absence of being able to do that, we can try to convince our coaches or try to convince our student athletes in our patient population to use shock absorbing insoles, because at the very least these are starting to show promising results. And when I say promising results, I mean that these are starting to show that we're at least getting some good results, that we're getting some decrease in the incidence of this condition. But at the end of the day, we still need more and more research to be done to take a look at these biomechanical deficits and really what's going on with these biomechanical deficits so we can start to implement treatment program or therapeutic exercise programs before we even get to the point of medial tibial stress syndrome. And we could probably say that for most injuries that we run into on a daily basis in our profession. And while calcium wasn't the answer, that's not to say nutrition supplementation isn't the answer. Like I said, a lot of us run into patient populations that, whether it's from disordered eating, not enough education about proper diet and nutrition, or the socioeconomic standards. We have tons of patients that we see yearly, and sometimes we may not even realize it until something happens to them, unfortunately, that have a decrease in nutrition that they need. So further research could definitely be done to take a look at nutrition supplementation to decrease not just medial tibial stress syndrome, but other musculoskeletal conditions in general. But like I said, we are a reactive society. So oftentimes we're not going to be able to prevent medial tibial stress syndrome from happening. We really wish we could, but in a year where I had 5 baseball players of all sports that had medial tibial stress syndrome, it's gonna pop up because whether they don't take care of themselves, whether they were predisposed from the start from a pre-existing injury or something along those lines, we're going to see medial tibial stress syndrome in the clinic. And when we see it, we need to be able to correct it or treat it and try to help that patient return to play as quickly as possible. So kind of jumping right back into the research, since we already talked about our PICO question here. In 2013, Winters conducted a systematic review where they took a look at a number of different treatments. And really none of these treatments they looked at didn't have real significant evidence, but there was suggested effectiveness, so numbers that were using those fun things like trending towards significance or possible clinical meaningfulness that were working, such as iontophoresis, phonophoresis, ice massage, ultrasound, periosteal pecking. So that's actually using the diagnostic ultrasound to perform that periosteal pecking, or extracorporeal shockwave therapy. Now, they didn't elaborate on the parameters that were used with any of these conditions as they performed their systematic review because none of them had significance. But at the same time, they still noted that we really don't have a standard treatment that's going to be our end-all be-all at this time, or at least as of 2013, for medial tibial stress syndrome. So as Johnson was working with their 2,700 shipmen, they didn't just look at, they didn't just look at insoles. They also took a look at using leg braces on those patients that had medial tibial stress syndrome to see if using an air cast rigid brace would allow them to return a person to activity sooner. And what they found was it really didn't have a benefit. The patient still suffered from medial tibial stress syndrome. They still had posterior medial pain while they were doing their weight-bearing conditioning, and it didn't have the effects that they needed it to have. They also found that trying to stretch out the triceps surae complex, which was suggested as a treatment in the early literature review that they did, didn't have an effect on reducing the incidence or reducing the return to run time for their patient population already suffering from medial tibial stress syndrome. So they were already starting to, unfortunately, tick more and more things off of our list. What they did note again was that 61% of the orthopedic surgeons, we kind of talked about this a little bit in our earlier question, recommended that the patient undergo rest. And there were numbers ranging from 4 weeks to 12 weeks, but the average within these surgeons was about 6.6 weeks to primarily treat medial tibial stress syndrome for fear of cause of stress fracture or further lower extremity injury because of that medial tibial stress syndrome and the changes in mechanics that it might cause or any other underlying factors it might be a part of. So, again, is this practical for our patient population that we work with on a day-to-day basis? I have not worked high school cross country, since I know that was the question that came up. That's the example I keep coming back to. But I imagine 6.6 weeks of not doing conditioning would effectively end your season regardless of whenever it occurred within it. Not going to be the most practical thing for our patient population, but if it's what we have to do to prevent a student athlete from having a stress fracture, so be it. That's what we have to do. But as clinicians and as diligent clinicians and people that want to see these kids return back to play, we need to be thinking about ways to speed this up and speed it up safely. We don't want to put people at risk, but we do want them to be able to do the things they love sooner than later. So Bruchot came out with a study in 2008 where they tested a program consisting of leg strength, coordination, and stretching exercises for reducing return to run time. And what they found was that they found no significant findings in their intervention groups. But now they're at least trying to use exercise to decrease that return to run time. Then in 2011, so just 6 years ago, Yuxel came out with a study where they started to actually say, well, we've already talked about these imbalances that are causing a problem. So why not try to correct this inversion-eversion imbalance in patients suffering from medial tibial stress syndrome? Also, what we're finding in these patients is that they have external rotation and eversion of their talus. So that talus isn't even sitting right in that ankle mortise in these patients. What are we doing to try to correct that as we're having this patient sit out for 6.6 weeks on average? And ultimately what they suggested was a rehab program that was going to be designed to improve these imbalances through inversion strengthening to have positive effects on this therapy. And while their study did not come to significant results, again, because of patient population and quality of the study, they were trending towards significance and they were getting towards clinical meaningfulness. And unfortunately, as we go through a lot of these studies, and unfortunately, not just for medial tibial stress syndrome, a lot of times when we talk about evidence-based practice, we get to use that nasty term, best available evidence. And if we don't have evidence that's better than what's available, we have to use that to, at the very least, put together the best plan that we can at that time. So just last year, a study came out from Camp where they used 47 service members, again, nice, good population that's going to do exactly what you want them to do, that were all already diagnosed with medial tibial stress syndrome. And they showed good results, and not just good results, they showed significant results with a short-term rehabilitation program that they put their patients through. Here's the problem, though. They did not elaborate on that rehabilitation program. They said that it was a program designed for strengthening of the lower extremity muscles. They did not mention which muscles those were. They did not mention anything else besides that. But one study they did cite was Yuxell's study, and it would be wonderful if they had elaborated. But what we do know is that they did a short-term therapeutic exercise program that showed good results for return to run time, and that they were citing these people that were putting forward the idea that we can use these rehab programs to correct imbalances to decrease return to run time. That's not to say, and not something that's really even quotable, that that's what they were doing in this study. But we're starting to find evidence that, yes, short-term rehabilitation programs do reduce return to run time. And yes, the idea is already out there within our research that we need to start to try to correct these imbalances while our patients out of their weight-bearing conditioning. So, clinical bottom line number 2. There is no consensus statement at this time on prevention and treatment of this long-recognized condition. We've known about medial tibial stress syndrome for about as long as we've been participating in athletics, and yet we still don't have a consensus statement on how to treat it. One thing we do know for sure, though, is that having a healthy BMI decreases our likelihood of medial tibial stress syndrome. So, if anything, that may be one of our most practical prevention methods, is encouraging and educating our patient population and trying to move them towards that healthy body weight. And then shock-absorbing insoles are starting to show promising evidence. The research out there still needs to be conducted on these prevention methods, but there's enough promising evidence right now to where you could probably comfortably go talk to your coaches and say, I think we need to start using shock-absorbing insoles so we can reduce the risk of medial tibial stress syndrome. And then as far as our treatment clinical bottom line goes, there are going to be biomechanical risk factors that seem to be associated with the occurrence of medial tibial stress syndrome that are setting us up for medial tibial stress syndrome. However, there's few, if any, studies that are showing clinicians trying to correct these risk factors as a means of prevention. We always end up using these as treatment after that goes on. But with this lack of studies, it should not limit you from incorporating some of these methods or employing these methods that are being put forth by the research available to try to prevent that medial tibial stress syndrome from occurring. And once it's there, and the first thing we have to do is remove our patients from weight-bearing activities, and that's not to say that they can't cross-train, so swimming, recumbent bike, things of that nature, but they need to be removed until those symptoms have subsided. Once those symptoms do subside, now that's going to be a situation where we can start a gradual return to play as the symptoms allow the patient return to play. Now, within those therapeutic exercise programs like I talked about, the vagueness of those studies should not stop us from trying to put together good research and trying to do the best we can with the best available evidence, because there is promising information coming out about decreasing that return to run or return to participation time, but we still need a more standardized methodology. Until we get that, we need to try to do what we can to correct that inversion weakness, decrease hip internal rotation, and hope that by correcting those hip imbalances and that inversion-eversion imbalance, that's going to put us at a place where those patients can return to play faster after experiencing medial tibial stress syndrome. And for those of you that were here for yesterday's lecture, you remember we had our slide that was talking about evidence-based practice and our three-legged stool. Well, one of those legs of the stool is obviously going to be clinician experience. And everybody here probably has their method or their best go-to method for treating medial tibial stress syndrome. So we're going to talk a little bit on what we'll do generally with student athletes at the University of Texas at Tyler. And cupping therapy is coming back up again because we talked again yesterday about how there are studies that are being prepared for submission that are showing that cupping therapy is improving blood flow. It's suspected to be taking care of that acidosis or that ischemic pain. We know it's not the bone that's causing a problem necessarily in most cases with medial tibial stress syndrome because there's no inflammatory markers within the bone itself. So we look at our culprits being that medial soleus as well as the flexor digitorum longus as being inflamed and causing a lot of that medial tibial stress pain. So we use this modality in an attempt to increase blood flow for our patients. And at the end of the day, it has been clinically proven to decrease musculoskeletal pain. And it's got, again, still those promising results for improving blood flow. And we use this based off of that principle at UT Tyler that we're having that medial soleus pain being or medial soleus involvement as a factor for medial tibial stress syndrome. So in this case, it really depends on the length of the patient's leg. If we have a 5'2" collegiate tennis player with medial tibial stress syndrome, we're obviously not going to use as many cups as our 6'7" center for our basketball team with their lower leg, just because, simply put, they don't have the same length of tibia. But for the most part, you're going to use as many cups as you need along that medial aspect of the lower leg as you see in this cupping array here. And as a general rule of thumb, we're going to leave these on for 15 to 20 minutes if the patient can tolerate it. If it's their first treatment time, a lot of times we'll only leave it on for 10 minutes to give them a chance to get used to the treatment, kind of get it acclimated to the sensations that they're going to experience. But then as they get used to it, we'll be performing this for 15 to 20 minutes. And then we're going to repeat this generally every other day. We're going to overlap our sites with this treatment. And we're always going to make sure that we have therapeutic exercise being used in conjunction with this. And we've started to do more and more work with using these imbalances that we found as we were going through our research to try to correct that inversion deficit. So we don't really focus as much on the everters, but we have started to see some decent results in terms of decreasing return to time by performing cupping therapy to decrease pain and then addressing those inversion weaknesses that we find. And again, like we talked about with the Baguantha cupping yesterday, if you have access to those silicone cups, you can apply the cupping treatment while you have your patient go through their exercises. So they'll have these cups on while they're doing their ankle therabands, marble pickups, toe scrunches, calf raises, any number of things that's going to be drawing more blood back to that medial soleus and is going to be allowing them to move through that pain-free range of motion again. Another study, or another method that we use is actually using leukotape. One of our team chiropractors kind of introduced this topic to us of placing what she calls tabs within those strips of leukotape and aligning them along that posterior medial tibia because it's going to allow you to provide more compression. Because we've all done that tape job where we put the X or the cross as we go through and just use either white tape or stretch tape to just try to provide some compression to that medial tibia for that patient that's suffering from pain. But in this case here, and this is a fun one that those 5 baseball players I mentioned earlier got to learn, shave your leg before you have this applied because leukotape is very sticky, it's a very strong adhesive, and either you shave your leg or the leukotape's going to shave it for you. So with this one here, if we're going to be applying this for a longer period of time, we might use the QD-Air, the quick drying adhesive, or the Tough Skin to give it a little bit longer life. But we'll start to apply tabs, and hopefully this picture comes up well here, right along that posterior medial tibia. And in this patient's case, it was just really along that distal third of their tibia is where their affected area was. As we apply those tabs, we start to cover up with more strips of leukotape where we're going to be overlapping by half and pulling from medial to laterally to add further tension and further compression along that medial muscular area on that tibia. And then we continue to cover up, overlapping by half, until we have that entire area covered. Generally, as a rule of thumb for us, just to make sure that the tape sticks, if they're going to be doing really anything else, we'll apply cohesive tape over the top of that and instruct them when it's time for you to go shower, take the cohesive tape off. But please do not take the leukotape off because now that we've applied it and it's fresh, there's a chance you're going to take a layer of skin or two with it. But just let it fall off whenever it's ready to fall off. And our patients that we work with absolutely love this and allows them to return to running much quicker than any time we don't have this type of a treatment applied. One thing that pops up a lot of times with this, though, at whatever level you're working at, is that leukotape is very expensive. It's not one of the cheaper tapes that we use. So I always encourage people that if you're considering using this, start with just plain old zinc oxide tape or Johnson & Johnson, whatever brand you have. Apply that to the patient, have them go test it out, run, walk around with it on for the day. And then if they like it at that point, that's when you can use the leukotape or whatever brand you decide to use at that point. But definitely try using that white tape first, so that way you're not applying something to a patient that's not going to ultimately be effective, because you'll get an idea if it's effective by using that white tape first. So kind of in conclusion on this one, we need to get a better understanding and we need a full understanding of the causes of medial tibial stress syndrome when we start to examine, or even when we're done examining our methods, start to prescribe treatments or prevention measures for medial tibial stress syndrome. And as us being diligent clinicians and sympathetic and responsible clinicians, we need to have a constant eye on the current research that's coming out. Like I said, there was that study that was a little disconcerting that I saw, that they said that most research that's coming out takes about 16 to 17 years to be fully implemented into clinical practice. That number I kept telling myself, and I keep telling myself, that number seems high, but at the same time, if that's the number they came to, it can't be that high. And if it's not a situation where we're keeping ourselves abreast of that research, we're just adding to that problem ourselves. So we need to be making sure we're keeping an eye out for Journal of Athletic Training, NATA News, or anything else that's coming out with information on how to treat not just medial tibial stress syndrome, but any of the conditions that we run into as athletic trainers. So at the end of the day, this is something that we could probably encourage most of the people that we know in the world. I can encourage myself to get back to a healthy BMI as well. But at the end of the day, we need to be talking to our patients and telling them that if they're going to be participating in athletic activities and exercising, they need to be trying to do so at a healthy BMI in order to reduce the risk of medial tibial stress syndrome and other lower extremity injuries. And until we can get a world where we have a population where everybody's at a healthy BMI, using shock absorbing insoles is probably going to be the best method that we have to prevent things on the short end. And in a perfect world, we get to the point where we start to implement these therapeutic exercise programs to correct whatever imbalances we find at the beginning of the season to further prevent this from occurring. And then if we do end up having medial tibial stress syndrome, I say when we have medial tibial stress syndrome occur in our patient population, then we need to put together a rehabilitation program that focuses on the areas of the greatest issue. Going back to our talk on our deliberate physical exam, as you're performing that physical exam, you're going to be able to note that decrease in hip flexion or internal rotation, that decrease in inversion strength, that imbalance with hip abduction weakness. And you're going to be able to say, at this point now, hopefully, we found this, you have medial tibial stress syndrome. While you're doing your cross training and we're getting things back under control, we need to make sure that we're addressing these weaknesses, because if we don't address these weaknesses or these imbalances, you're going to be right back in my office again, and your coach is going to be even more pissed this time around because you didn't fix what was wrong in the first place. So again, we need to increase that strength in those inversion in these patients. We need to increase eversion and hip internal rotation range of motion, and it should be on there too, but we need to increase strength for hip abduction as well to try to bring our patients back to good, healthy biomechanics for their gait and their stance when they're running. And then at the end of the day, we also have to take into account patient-reported outcomes. If we didn't take into account patient-reported outcomes in our clinic, we would never have kind of gotten to where we are right now with our cupping therapy that we're using or with the leukotaping that our chiropractor introduced to our patients. And we would still be having longer return to run times for these patients. So at the end of the day, you need to be willing to try new treatments with less evidence as of right now that are being used for other conditions and other exercises that may not necessarily have the evidence, because as of right now, your expertise is a lot of times going to be what you have to fall back on until more research can come out on how to treat and prevent this condition. But the big takeaway with this one, again, that ounce of prevention is going to be worth a pound of cure. We need to be encouraging our patients to be healthy in terms of BMI, in terms of competing body weight and everything in general. We need to be trying to find those imbalances before they become an issue. We need to encourage our patients to use proper footwear, and we need to encourage them to gradually increase their activity. But then at the end of the day, we need to be ready to cure whatever's going on at that time. And so, like I said, I'm pretty sure the quizzes were flipped, so this might be under the Diagnosing survey. So if it is, we can go ahead and get started on this side of things. So as of right now, true or false, there have been no evidence-based consensus statements produced and popularized on the treatment and prevention of medial tibial stress syndrome. Produced, popularized are two of the big things here, because as far as consensus statements go, nothing's really out yet. We have more and more studies that are coming out showing promising results for treatment, but nothing that we can really qualify as a consensus statement. And if that consensus statement's out there somewhere, the people that made it certainly aren't popularizing it very much yet. So this one is absolutely true. So next one up, which of the following treatments has shown the most consistent positive outcomes? Are we going to talk about, and this actually, my mistake, should be prevention measures. So running programs with a gradual progression, insoles to disperse ground reaction forces, correction of gait mechanics, or therapeutic exercise. And remember, we had that answer up to 50% of the population. That one randomized control trial that came out showed that they were getting even better than 50% outcomes in terms of reduction in medial tibial stress syndrome. But using good insoles that are shock absorbing to disperse that ground reaction force right now is going to be our most consistent positive method for preventing medial tibial stress